Sir, please start.
Yeah. A very good morning to all of you respected doctors. It's indeed a pleasure for me to welcome you all for this very interesting webinar today on a topic of ECG Update 2020, a COVAI Heart Rhythm Summit. And for this webinar, we have two very eminent panelists today. I'll have a brief introduction of them. Dr. Arun Gopi sir, he is a senior interventional cardiologist. He is a director and head Department of Electrophysiology and Heart Failure at Metromed International Cardiac Center, Kozhikode. And the topic on which sir will be speaking is Wide QRS tachycardia, ECG-based approach. And our second faculty for today's webinar is Dr. M. Lawrance Jesuraj sir. Sir is also a consultant cardiologist and electrophysiologist, Division of Cardiac Pacing and Electrophysiology at KMCH Heart Institute, COVAI Medical Center and Hospital at Coimbatore. And sir's topic is Usefulness of ECG in Non-Cardiac Conditions, a case-based approach. So with this introduction, I hand over the session to Dr. Arun Gopi sir, our first speaker today. Gopi sir, please.
Yeah, thank you for the introductory words. Today we have two sessions, and I start off the session with a talk on approach to wide QRS tachycardia. Let me get my slides on, and I hope my slides are in slideshow mode and you're able to see it, and my audio is clear. Okay. So welcome you all, and to start off the ECG update, the topic for the next 1 hour or so is going to be one of the uncommon rhythm disorders that you may see in medical practice, that is wide QRS tachycardia or broad QRS tachycardia. It is, although it is not so common, but this has disastrous consequences. So a quick analysis and a quick therapeutic decision has to be implemented. And as with myocardial infarction, time is life here in this scenario. And the earlier you act, the higher chance of your patient surviving this uncommon rhythm disorder. So this would be my format. So I would get the problem defined for you. We will discuss the common differentials that should come to your mind when you see this kind of rhythm strip. We'll have a brief look at what is the mechanism of this kind of rhythm disorders and how to get about them, not only based on the ECG analysis, but also a quick look at the history. What are the rapid things you need to look on physical examination? And before concluding, we'll also have a look at the common ECG algorithms that are available on deciphering wide QRS tachycardias. So to set the ball rolling, we need to understand what defines a wide QRS tachycardia. So as wide QRS tachycardia, as the nomenclature itself is self-explanatory. Wide QRS means a QRS duration which is more than 120 milliseconds. And tachycardia, as you all know, is by definition any rhythm disorder with a rate which is more than 100 beats per minute. So wide QRS tachycardia means nothing but a rhythm with a rate which is more than 100 beats per minute and a QRS duration of more than 120 milliseconds. The two most common differential is simply ventricular tachycardia and supraventricular tachycardia with aberrance. By definition, ventricular tachycardia means 3 or more consecutive ventricular beats, that means wide QRS beats, with a rate which is more than 100 beats per minute. Electrophysiological perspective of you want an objective way of differentiating supraventricular tachycardia from ventricular tachycardia. The differentiating line or the Lakshman Rekha is actually the bundle of His. Any rhythm disorder which originates below the bundle of His is ventricular tachycardia, and any rhythm disorder with originating focus above bundle of His is by definition or from an electrophysiologic perspective is a supraventricular tachycardia. So whenever you see a patient with wide QRS tachycardia, the first thing you need to look at is whether the rhythm is regular or irregular. You just look at the RR variability. So if the RR variability, that is the RR between the largest and smaller, the largest and smallest is actually less than 120 milliseconds, it's a regular wide QRS tachycardia. And if it is regular wide QRS tachycardia, again, the three differentials you should keep in your mind is ventricular tachycardia, which is the most common etiology. The other differentials are supraventricular tachycardia with aberrancy, or antidromic tachycardia, or pathway mediated tachycardia. On the other hand, if you are dealing with irregular wide QRS tachycardia, the common differentials are either it's a polymorphic ventricular tachycardia, or it's an atrial tachycardia or atrial flutter with pre-existing bundle branch block, or an atrial tachycardia or atrial flutter conducting down an accessory pathway, what we call as a pre-excited atrial fibrillation or atrial tachycardia. In view of the shortage of time, I'll be sticking on to the approach towards a regular wide QRS tachycardia, although I'll be also giving you some glimpses of some case scenarios where we see irregular wide QRS tachycardia as well. But the focus of today's talk would be on regular wide QRS tachycardia, which is a much more common clinical problem you see in practice. Essentially, people in the emergency department are going to see it more, or people dealing with critically ill patients are going to see them more. Statistically, you all know that common things come first. So a patient comes to you with regular wide QRS tachycardia. Etiology-wise, most prevalent disorder presenting with this kind of an ECG strip is going to be ventricular tachycardia. So if you label regular wide QRS tachycardia as ventricular tachycardia, you're going to be right in 70 to 80% of time. The other common etiology is supraventricular tachycardia with aberrancy. But you should realize that of all the wide QRS tachycardias you see, SVT with aberrancy constitutes about just 20%. So 1 out of 5 patients with wide QRS tachycardia is only going to have SVT with aberrancy. Although theoretically, we discuss a lot about pre-excited tachycardias or antitromic tachycardia, pathway mediated tachycardia, ventricular paced rhythms as presenting as wide QRS tachycardia. But you should realize that although they are of more academic interest, but in practice, they just constitute 5% of all the wide QRS tachycardias you're going to see in clinical practice. So fancy things kept to be lower down in the list of differentials. Before diagnosing antitromic tachycardia as a cause of a wide QRS tachycardia in your patient, remember that only 1 out of 20 patients coming to you with a wide QRS tachycardia is going to have antitromic tachycardia or pathway mediated tachycardia. It's just so uncommon. So this is taking you back to your physiology classes. This is the native conduction system on one side, and the conduction velocity is depicted on the right-hand side. So this clearly elucidates why in a normal sinus rhythm you have a narrow sleek QRS. In a normal sinus rhythm, if you look at the picture on the right, I hope you can see my pointer. The ventricular activation happens from the bundle of His into the right bundle and left bundle, and then through the His-Purkinje system into both the ventricles simultaneously. So there's simultaneous activation of right ventricle and left ventricle from the interventricular septum through a very rapidly conducting conduction system, rapidly conducting fibers, what we call the bundle branches and the Purkinje fibers. See, the bundle branches conduct at a speed of 2 meters per second, Purkinje fibers conduct at a speed of 4 meters per second. On the other hand, just note that the ventricular muscle conducts at a speed of 0.5 meters per second. So this is just 1/8 of the speed of the Purkinje fibers, or 25% of the speed of the bundle branches. And this will make you understand why a person, when he comes to you with this kind of rhythm, he has a wide QRS. So as I said, if a person comes to you with wide QRS tachycardia, 80% of the time, the etiology is going to be ventricular tachycardia. 70 to 80% of the time, the etiology is simply going to be ventricular tachycardia. So ventricular tachycardia originates from either of the ventricles. So it is originating from a myocyte, and the impulse transmits from one myocyte to another myocyte. So there is myocardial transmission of impulse. You had seen in the earlier slide that the myocardial impulse transmission happens at just about 0.5 meter per second. And then there is sequential activation of ventricle. So if a VT originates from left ventricle, it depolarizes the entire left ventricle first and then the right ventricle. So there is myocardium to myocardial transmission of impulse, and there is sequential activation of one ventricle followed by the other ventricle. This explains why a ventricular tachycardia results in a wide QRS rhythm. On the other hand, the second most common differential, as I said, in about 50% of cases, you might have a supraventricular tachycardia with absence. So that means the impulse originates from above the His bundle, but conducts to the ventricle through either a diseased conduction system, which is pre-existingly diseased, or there is a rate-dependent prolongation of conduction, which delays the conduction, and so there is still conduction happening on the conduction system, but since it is diseased or there is a physiologic conduction delay in this His Purkinje system or the conduction system, there is a wide QRS happening. Again, if the person has a right bundle branch block, the left ventricles get activated first, and then subsequently the right ventricle gets activated. So there is sequential activation of ventricle, which again explains other mechanism of having a broad QRS rhythm. The third mechanism, as I said, the uncommon mechanism is a pathway-mediated tachycardia. So in people with Wolff-Parkinson-White syndrome, or a person who has an accessory pathway, atrioventricular pathway, which connects, you can see this pathway connects the atrium to ventricle. So the ventricular activation first happens at the site of insertion of the pathway, and from that side there is, as with the ventricular tachycardia, a myocardium to myocardial transmission of impulse, and there is a sequential activation of one ventricle followed by the other ventricle. So that explains why a pathway-mediated tachycardia or an antiatromic tachycardia has a wide QRS. Now, for people who don't want to go into the complex algorithms or the complex nuances of the ECG, if a person comes to you with a regular wide QRS rhythm, if you don't want to look at all the algorithms, or you don't want to look at all the intricacies of the wide QRS rhythm approach, or if the patient is unstable, like the patient is in pulmonary edema, he has a low blood pressure, he has had a syncope, or he's having severe angina, in those cases, you don't waste time on ascertaining the correct mechanism of wide QRS tachycardia. The simplest approach is to just presume that all wide QRS tachycardias are ventricular tachycardia. Just because if you do that, 80% of the time you are going to be correct. If you want to improve your positive predictive value, then just take 1 minute and take a history of prior myocardial infarction or history of LV dysfunction, or see whether the patient has a structurally abnormal heart. Just go rapidly through his old records. If he has suffered a myocardial infarction in the past, whether he has a document which says that he has a scar in the myocardium, whether he has LV dysfunction in a echo which was done earlier, or if he's a post-coronary bypass surgery with an established myocardial disease, or like he has a hypertrophic cardiomyopathy, a structurally abnormal heart. So if he has a prior myocardial infarction, a history of LV dysfunction, or a structurally abnormal heart, simply diagnose any wide QRS tachycardia in such a substrate to be ventricular tachycardia, because you are going to be correct in 98% of the time. So your positive predictive value in the presence of these two important history is 98%. You need to take, in an unstable patient, you need to quickly diagnose them as VT, because ventricular tachycardia, as you know, can be life-threatening. Even if you wrongly diagnose supraventricular tachycardia as ventricular tachycardia, it is really safe, because majority of the therapies that you employ for ventricular tachycardia is really safe in supraventricular tachycardia. On the contrary, if you make a diagnosis of supraventricular tachycardia erroneously and you use agents like adenosine, sometimes they can be fatal in patients with ventricular tachycardia. The essential importance of the precise diagnosis actually comes in the long-term prognosis. But all said and done, if you have a positive predictive value of 98% with just a history of myocardial infarction and LV dysfunction, then why do we do this entire talk and entire exercise of ascertaining the mechanism of wide QRS tachycardia? This is because the long-term prognosis really differs. And you need to understand that 20% of the time, you can have supraventricular tachycardia masquerading as a wide QRS tachycardia. And so you need to understand these patients well. So why does a supraventricular tachycardia present with wide QRS rhythm? See, as I said, it can happen because if the patient has a pre-existing bundle branch block, or if there is a rate dependent aberrancy, you can have a wide QRS rhythm. Another mechanism is if the patient is on some sodium channel blocker, like a class 1A or class 1C agent, or if the patient has some electrolyte disturbances like hyperkalemia, which broadens the QRS. In such a scenario also, any supraventricular tachycardia getting conducted down can have a wide QRS rhythm. The third mechanism, as I said, is via an accessory pathway. So here, as I said, the accessory pathway connects the atrium to ventricle, and any person who has an antegradely conducting accessory pathway will have a short PR interval because the ventricle is excited before the AV nodal depolarization or AV nodal His-Purkinje system mediated depolarization of ventricle, which we call the ventricular pre-excitation, which is seen on the surface EKG as a short PR interval. So the ventricle gets depolarized very early. So the QRS onset is much earlier. So you have a short PR interval. You have a initial ventricular depolarization, which happens from myocardium to myocardium. So there's a slow conduction of impulse, which gives you a slurred upstroke of the QRS, which we call the delta wave. And since the ventricular activation is actually a fusion activation between the transmission via the accessory pathway and the native conduction system, there is a wide QRS which happens because there is myocardium to myocardial transmission of impulse. And that is why you have this triad of WPW syndrome, which we denote as a short PR interval, a slurred upstroke of the QRS, which we call the delta wave, and wide QRS. So a short PR interval, a delta wave, and wide QRS constitutes the triad of what we call as Wolff-Parkinson-White syndrome pattern. And if these patients are symptomatic, we call them Wolff-Parkinson-White syndrome. So patients with this kind of accessory pathway conducting the atrium to ventricle, if they have a supraventricular tachycardia, like an atrial tachycardia, that atrial tachycardia or atrial fibrillation can conduct via the accessory pathway now and can result in a wide QRS, which is one example, which is one cause for a wide QRS tachycardia. On the other hand, they can have a impulse which gets transmitted down the accessory pathway. Sorry, it can get conducted down the accessory pathway and can go retrograde via the His-Purkinje system and AV node back to the atrium, and can set up a macro reentrant circuit between the atrium, the accessory pathway, ventricle, and the native conduction system, and thereby create what we call as an antitromic tachycardia, which also will result in a wide QRS tachycardia because the ventricle is depolarized over the accessory pathway, and so is going to have this slurred upstroke and broad QRS rhythm. Rarely you can have an antegrade conduction over one pathway and retrograde conduction over other pathway, which we call a duodromic AVRT, which is very, very uncommon, and I would try to keep it away from this from the current discussion because it is really uncommon. Sometimes you might see this kind of rhythm. If you see this is again a broad QRS tachycardia, but does not come into any of the differentials that we discussed earlier. If you can see here, you can actually see a spike at the onset of QRS. This is nothing but a pacing spike, and this person has a pacemaker which is implanted. As you all know that the pacemaker depolarizes the ventricle myocardium directly and could result in a paced beat, which is a broad QRS rhythm. And so any pacemaker mediated tachycardia is going to have a broad QRS rhythm. This is another example of a very broad QRS tachycardia. Simply looking at this would give us a rapid assumption that this is simply ventricular tachycardia because of the broadness of the QRS. But if you look at the history of this patient had past history of atrial flutter and atrial fibrillation and was put on flecainide. Flecainide, as you all know, is a class 1 sodium channel blocking agent. And since it's a sodium channel blocking agent, it results in a broad QRS rhythm. And when the supraventricular tachycardia gets conducted down, in presence of a sodium channel blocker like quickened, you can have an SVT, which can result in a broad QRS tachycardia. This is again the antitromic tachycardia, which I was alluding to earlier. This patient has baseline evidence of pre-excitation in the form of a short PR interval. You can see lead B1, lead AVF, lead 2, lead 3, which all show a short PR interval, a slurred upstroke of the QRS, which is seen well on the precordial leads as well, and a wide QRS, which indicates that there is an antigradally conducting accessory pathway. And when this impulse get transmitted purely by the accessory pathway antigradely and retrogradely via the native conduction system, it sets up what I said earlier, the antitromic tachycardia. And here you can see that the QRS looks, the onset would look just the same as the sinus rhythm, but the broadness increases because the entire ventricle is depolarized via the accessory pathway, and you can have maximally pre-excited ventricular depolarization in a person with an accessory pathway, antitromic tachycardia. Similarly, if it is conducted via one accessory pathway down and another accessory pathway up, you call it duodromic tachycardia. This is another person who had an accessory pathway. Here, the person had an atrial flutter. So in atrial flutter, you know that the atrial impulse happens at a rate of 250 beats per minute. And so, in presence of an accessory pathway, it can conduct rapidly down this accessory pathway and can result in a rapid or very fast broad QRS tachycardia, which is nothing but a pre-excited atrial flutter. It's nothing but atrial flutter, which is conducted down via the accessory pathway to the ventricle and results in a broad QRS. This is one ECG I don't want any one of you to forget, because this is a sure catastrophe or a sure time bomb. If a person comes to you with this ECG, never waste time in understanding the mechanism. The simplest way to look at this ECG is it is really fast. It would be happening at somewhere rate between 250 to 300. It is going to be very fast. The QRS is really going to be broad, and it is going to be irregularly irregular. This is nothing but pre-excited AFib and is a very common cause of sudden cardiac death in individuals with accessory pathway. So whenever you see a fast, broad, irregularly irregular rhythm, it's always a pre-excited AFib. The evidence of accessory pathway, as you all know, is seen in the evidence of slurred upstroke of the QRS. You can see in B4, B5 and all, you have a slurred upstroke of the QRS. It's an atrial fibrillation because it is irregularly irregular. The actual QRS morphology changes from beat to beat, indicating that there is a competition between the native conduct system and the accessory pathway in what impulse is getting transmitted to the ventricle. And that is why, contrary to AF with aberrancy, in which the QRS morphology do not vary from beat to beat much, but in pre-excited AFib, there is a lot of inter-QRS variability in the same ECG. Now, this is another ECG which has fooled many of our intensivists, many of our critical care nurses. You see these kind of ECGs, the lower panel ECGs you can see. You see these kind of ECGs in the ICU telemetry. You see these things in patients who have been monitored with defibrillators in the room on your telemetry screen. And when you rapidly run to this patient and look at him, the patient, despite these kind of crazy ECGs, the patient is very comfortable. You look at the saturation probe, it is showing a regular rhythm. Patient is hemodynamically stable. Patient looks quite dissociated with this kind of ECG. So this is nothing but an artifact. The clue to this is, look at these high frequency signal tracings which indicate the native depolarization in different leads. So these are the high frequency signals. Within the high frequency signals have been marked with arrows which indicate the native sinus beats or native depolarization, which would indicate that these are artifacts and not really wide QRS tachycardia or the polymorphic BT for which many of the patients have received shocks. Now we approach to wide QRS tachycardia. As I said, always look at history and physical examination. Look for evidence of, as I said, evidence of structural heart disease or history of prior myocardial infarction, history of LV dysfunction. Prior history of myocardial infarction or LV dysfunction would easily make a diagnosis of ventricular tachycardia with a positive predictive value somewhere between 95 to 98%. On the other hand, a young patient with history of recurrent episodes of tachycardia for 3 or more years, it is more likely to be a supraventricular tachycardia with aberrancy. When you do the simplest calculation of just looking at the history alone, in the presence of structural heart disease or myocardial infarction, this paper by Masood Akhtar clearly says that irrespective of what you see on ECG, if the person has structural heart disease or history of prior myocardial infarction, you're going to have any Wide QRS tachycardia coming to you as VT in 95% of patients. And if there is a prior history of myocardial infarction, every Wide QRS tachycardia is going to be a VT except in 2% of cases. So 98% of the time, a person with prior myocardial infarction or Wide QRS tachycardia is going to be VT. Now, these are the physical examination findings that you need to look at. These are only for astute clinicians. Nowadays, nobody is going to spend time looking at the neck in a person with a Wide QRS tachycardia, but the essential clinical examination details that you need to look out for is evidence of hemodynamic, evidence of AV dissociation, that is the Cannon waves, which you can see here on the neck in both of these patients. These Cannon waves actually indicates AV dissociation and is a sure shot sign of the rhythm being a Wide QRS tachycardia. One other thing, important take-home message that you need to take out of this lecture is that hemodynamic stability of a rhythm does not indicate supraventricular tachycardia or a benign disease. Hemodynamic stability has nothing to do with a diagnosis of VT or SVT. The other thing you need to understand is any AV nodal blocking maneuvers like Valsalva, carotid sinus massage, if it is able to terminate a Wide QRS tachycardia, it strongly suggests that it is a supraventricular tachycardia, although it can rarely happen with ventricular tachycardias as well. Now, suppose you are doing an echocardiogram and you see that the patient suddenly goes in for a broad QRS tachycardia or a tachycardia. You don't have time to shift them to the ECG and take ECG strip and see what is happening. The simplest way in these scenarios, if you're doing an echocardiogram and patient goes in for a tachycardia, simply put an M-mode cursor on the parasternal long axial view where you can get a ventricular cut as well as the atrial cut. This is the LV outflow as well as this is the left atrial on the lower part. So you can see the atrial contraction. The lower panel shows the LA contraction and the upper panel shows the right ventricular contraction. You can see in this rhythm, clearly the ventricular contractions are more than the atrial contraction, indicating that this is AV dissociation, more V's than more A's, and it simply indicates that the patient has ventricular tachycardia. Now, pharmacological agents which come handy are any AV nodal blocking agents like adenosine, diltiazem, verapamil, digoxin. Termination of a Wide QRS tachycardia with these AV nodal agents in most of the time would indicate ventricular tachycardia. This is not a 100% rule, because you can have ventricular tachycardias which terminate with verapamil, or rarely ventricular tachycardias which terminate with diltiazem or adenosine. But majority of the time, if you have a Wide QRS tachycardia and it terminates easily and reproducibly with AV nodal blocking agents like adenosine, it usually indicates that it is supraventricular tachycardia. While on the other hand, termination with amiodarone, any Wide QRS tachycardia if it terminates with amiodarone, it does not help in differentiating supraventricular tachycardia versus ventricular tachycardia. Now, if you have the luxury of getting his baseline ECG, like if the patient is in a stable Wide QRS tachycardia and you want to clearly understand the diagnosis before you jump into the treatment part, look at his baseline ECG. Any evidence of structural heart disease, like evidence of ischemia on the old ECG, evidence of old myocardial infarction, presence of Brugada syndrome, presence of these epsilon waves. These are epsilon waves which you can see. These are nothing but, you can see at the terminal part of QRS, a slur in the anterior precordial leads V1 to V3 have a slur in the terminal part of QRS, what we call as the post-excitation, just synonymous to the pre-excitation that we say in pathway. Here is a post-excitation or slurred upstroke of the QRS, which indicates a slow conduction in the right ventricle, what we call as the epsilon wave, and is very pathognomonic of arrhythmogenic RV dysplasia, although it is seen only in 30% of cases with arrhythmogenic RV dysplasia. Similarly, a slurring in the QRS, which we call the fragmented QRS, evidence of left ventricular hypertrophy, suggestive of hypertrophic cardiomyopathy, all these things. Evidence of structural heart disease always indicate that the patient has a Wide QRS tachycardia due to ventricular tachycardia. Now, this is another ECG of a person who came with a Wide QRS tachycardia. Looking at the ECG, you might get confused, but things become very easy when you look at the baseline ECG. You see that the baseline ECG person has a similar broad QRS pattern, and the tachycardia here is clearly SVT with pre-existing bundle branch block, because the baseline ECG itself shows a similar QRS and axis. So whenever you are dealing with a wide QRS tachycardia, simplest approach is look at the QRS. If your QRS is very compatible with a typical bundle branch block pattern you are aware of, like a left bundle branch block or right bundle branch block, invariably this is supraventricular tachycardia with aberrancy. On the other hand, there are some very reliable criteria to differentiate VT from SVT with aberrancy. They are AV dissociation, fusion beats, capture beats, the QRS duration, axis, the concordance. And so those things I'll be alluding to for the second part of my talk. So beginning off with the most specific sign to differentiate ventricular tachycardia from supraventricular tachycardia with aberrancy, it is AV dissociation. So look at the lead one in this. You can see that the atrial depolarization as evidenced by the P wave here, and the ventricular depolarization as evidenced by the QRS here in lead V1 and lead 1 is very clear. You can see that the P waves and QRS are totally divorced. Actually, they don't talk to each other. They are not connected at all. They are totally dissociated. This is what we call AV dissociation. Again, alluded to in this ECG. You can see the lead 2 here. The P waves walk totally dissociated from the QRS, what we call again as AV dissociation, and it is a very, very specific criteria for VT with a specificity close to 100%. But the unfortunate thing is that AV dissociation happens only in 20 to 50% of all ventricular tachycardias, and very, very rarely supraventricular tachycardias can have AV dissociation, although clinically not seen. One clue to the presence of AV dissociation is variation in the QRS amplitude. You look at the lead 3 here, you can see that the thermal part of QRS has some variation of subtle changes which indicate the presence of the P wave or the atrial depolarization, and that is indirect evidence of AV dissociation. The subtle changes in the QRS amplitude indicate the presence of AV dissociation. You can also see in lead to this strip B here again, these things indicate AV dissociation. But you should realize that 30% of ventricular tachycardias can have one-to-one retrograde VA conduction, and in those cases, AV dissociation is not seen. And AV dissociation can also be unmasked by carotid sinus massage or AV nodal blocking agents like adenosine. Now, if you see this kind of ECG, look at what is the rhythm, you might be confused. It is a broad QRS tachycardia, it could be ventricular tachycardia or SVT with aberrancy. Sometimes in these scenarios, one thing which really comes in handy is the Lewis lead. What you do for Lewis lead is nothing but the RA, right arm electrode, is placed on the second right intercostal space adjacent to the sternum, and the left arm electrode, you can see as in the picture, is placed on the fourth right intercostal space close to sternum. And the strip which is recorded between this right arm and left arm is called the Lewis lead, between the second right intercostal space and the fourth right intercostal space. And when you have Lewis lead, it clearly depicts atrial depolarization better, and in the same rhythm you can clearly see P waves well dissociated from the ventricles. You can see P waves here, you can see P waves here, you can see P waves here. So AV dissociation is unmasked by the Lewis lead, and it clearly helps us in making a diagnosis of ventricular tachycardia. Now, other features which are very specific for AV dissociation is, see, that they are called fusion beats and capture beats. So this is a person who has a ventricular tachycardia. He has ventricle which is getting depolarized from the ectopic focus inside the left ventricle. He also continues to have sinus depolarization based on the rates and mutual competition between these two competing rhythms. Sometimes during the ventricular tachycardia, the native sinus depolarization can be transmitted via the His-Purkinje system and can depolarize the entire ventricle, which we call the capture beat. So capture beat will begin off with a P wave, would have a QRS which is just similar to the native sinus QRS or sinus rhythm QRS, and this is what we call capture beat, because this clearly indicates a feature of AV dissociation. The atrium and ventricle are dissociated. Sometimes the ventricle, on the other hand, can have a depolarization which is, sometimes a ventricle can have partially get depolarized from the ventricular ectopic focus and partially get depolarized from the native sinus impulse. And so that is what we call a fusion beat. So this is a fusion beat. Fusion beat, the QRS would be somewhere between the capture beat or between the sinus QRS and between the ventricular tachycardia QRS. So it will be a mixture of the ventricular tachycardia QRS and sinus QRS, and that's what we call the fusion beat. So this is a rhythm strip of a person having a broad QRS tachycardia. This is the broad QRS tachycardia. You can see a P wave here, followed by a QRS, which is just not similar to the first beat. That is the first beat of ventricular tachycardia, and the second beat is actually slightly different because second beat is slightly narrower, and there's a preceding P wave, which is nothing but a fusion beat. As you move forward, you can see another beat, P wave here. And the next QRS after the P wave, or the fourth beat in this strip, has a QRS which is really narrow. It is nothing but a capture beat, and it is because of the ventricular capture by the native sinus depolarization. And as you subsequently see in the rhythm strip, you can clearly see P waves totally dissociated from the QRS, indicating AV dissociation. So you have AV dissociation, fusion beats, capture beat, all in the same strip. Again, on the lead 2 baseline rhythm strip, you can see P waves totally dissociated, indicating AV dissociation. You can see a P wave followed by a very narrow beat, narrow QRS beat, which is nothing but a capture beat. And you can see some QRSs which are intermediate between the sinus QRS and between the VT morphology of the QRS, indicating fusion beats. All these are very specific for ventricular tachycardia. The third thing is QRS axis. So, sorry, the third thing, next thing is QRS duration. 70% of ventricular tachycardias have a QRS duration which is more than 140 milliseconds, while none of your SVTs are going to be so broad. So as I said, look at the earlier explanation of the broad QRS rhythm. I said in ventricular tachycardia, as there is myocardial transmission of impulse and sequential activation of ventricle, the QRS can be as wide as any duration, because the myocardial to myocardial transmission of impulse can take longer time if you have really scarred left ventricle. And on the other hand, if you have SVT aberrancy, still some part of ventricle is always depolarized over a rapidly conducting his Purkinje system or the conduction system. So QRS, even if it is broad, it cannot be broader than a particular level. So if a person has a right bundle branch block, QRS duration of up to 140 milliseconds can happen with SVT aberrancy. So in an RBB, if the QRS duration is more than 140 milliseconds, it is clearly VT. For left bundle branch block, in SVT, the QRS duration can go up to 160 milliseconds, but never beyond that. But mind you, when you make these assumptions, any antiarrhythmic agent, as I said in the earlier example, if you give a sodium channel blocking agent, antiarrhythmic agents can really broaden the QRS. Similarly, if you have a VT, which is originating from the interventricular septum, or VT, which is originating from the native conduction system. So, example, a vesicular VT, or intervesicular VT, or a septal VT. So here, despite it being a ventricular tachycardia, it originates from the septum, the simultaneous activation of both ventricles, and since it enrolls the conduction system very early, have rapid depolarizations within the ventricle, and so despite being a ventricular tachycardia, the person can have really narrow QRS beats. Actually, it's not very narrow QRS by definition, but compared to all the VTs that you see, these are the VTs, that is the septal VTs and the idiopathic VTs, and mediated via the conduct systems, which can have a relatively narrower QRS compared to the myocardial VTs. Now, next, coming to the QRS axis. As you all know, the normal axis is between -30 to +90. Whenever you have a northwest axis, you should always understand that a northwest axis always indicates VT. Whatever kind of aberrancy you have, whatever kind of bundle branch blocks you have, you can never ever change axis so much that it becomes a northwest axis. So that is why whenever you have a northwest axis or a prominent R in AVR, a prominent R in AVR clearly indicates that it is northwest axis. It's a sure short sign that you are dealing with ventricular tachycardia. if the axis difference between the sinus rhythm and broad QRS rhythm is more than 40 degrees. Like if the sinus, in sinus rhythm, the axis is minus 30, and during the tachycardia, the axis is plus 150. If the difference in axis is more than 40 degrees, it always indicates that you're dealing with ventricular tachycardia. Combinations of left bundle branch block with the right axis or right bundle branch block with left axis is always indicative of VT. The next thing you need to remember is the QRS concordance. So suppose you have all the QRS from V1 to V6 being positive. This is what we call positive concordance, and this is very specific for VT or antidromic tachycardia. Suppose you have all the QRS from V1 to V6, all the QRS are negative. That's what we call negative concordance. Negative concordance are always very specific for ventricular tachycardia. So concordant pattern, the precordial leads are uncommon with supraventricular tachycardia, only exception being an antidromic tachycardia can have a positive concordance. The specificity of this concordant pattern is clearly close to 90%, but unfortunately, as like with AV dissociation, is seen only in 20% of VTs. Negative concordance, whenever you say, as shown in this ECG, you have negative concordance across the precordial leads and a positive AVR. Negative concordance is clearly an indicator of northwest axis. That is the depolarization always going from away from the anterior chest precordial leads, indicating an VT which is originating from near the apex. So negative precordance, an extreme northwest axis, all these are very specific for ventricular tachycardia. As I said, any evidence of structural heart disease. You all know that Q waves indicate an electrical window in the myocardium, and Q waves, even if it is present during sinus rhythm or during wide QRS tachycardia, indicate the presence of a scar and are very much in favor of VT. See this example, this patient had an old anterior myocardial infarction. You can see the native sinus QRS with QS pattern in V1 to V4. Even during VT, the Q waves are retained. So generally, a person with ventricular tachycardia, on the other right-hand panel, you have a person who had an old inferior myocardial infarction during VT. Again, the inferior lead Q waves are retained. So Q waves are generally retained during wide QRS tachycardias, and so you can still look for evidence of Q waves in the wide QRS rhythm. And when you have Q waves in a wide QRS rhythm, it indicates old myocardial infarction. And in such scenarios, it is always going to be ventricular tachycardias. Unfortunately, QR patterns are seen only in 40% of patients in the patients with post-myocardial infarction VT. You should also remember that dilated cardiomyopathy patients can have Q waves in the absence of old myocardial infarction. And so similarly, in dilated cardiomyopathy mediated ventricular tachycardia, you can have Q waves which are only seen during VT and not seen in sinus rhythm. Rarely, pseudo Q waves can be seen in supraventricular tachycardias like AVNRT, which is nothing but actually an atrial depolarization falling on the QRS, or it can be rarely seen in accessory pathway mediated tachycardias. Now, the next pointer is based on QRS duration. Suppose in the baseline, like you see on the left-hand strip, you have a baseline ECG which shows a wide QRS rhythm. So baseline itself, the person has a wide QRS rhythm. Now, if this person during the tachycardia has a narrow QRS tachycardia or a QRS which is narrower in tachycardia than in sinus rhythm. So, person has a baseline wide QRS rhythm. During tachycardia, the QRS narrows down further. This is a sure shot sign that the person has ventricular tachycardia. This is because if the person has an aberrant conduction or a pre-existing bundle branch block, suppose he has a left bundle branch block, any supraventricular tachycardia is going to have a persistent left bundle branch block, or the QRS duration will be same or broader than the sinus rhythm QRS. But suppose if a person has a left bundle branch block on baseline, and if the ventricular tachycardia originates from the left ventricle, you are going to have a narrower QRS during tachycardia than in sinus rhythm, because the left ventricle will be activated faster than in a diseased bundle branch. Now, in my ventricular tachycardia, as I said, the initial depolarization is myocardium to myocardium, and so the initial depolarization is always going to be slower. And this is what we call the intrinsicoid deflection, or the initial depolarization of the QRS. what we call as intrinsic oil deflection. It is ascertained by what we call the PAVA criteria, where we actually look at the time to the peak of R wave. From the onset of QRS to the time to the peak of R wave is measured what we call as the R wave peak time. If it is more than 50 milliseconds, it is a sure shot indicator that you are dealing with myocardial VT. It indicates myocardial to myocardial transmission of impulse, and a PAVA criteria or R wave peak time more than 50 milliseconds indicates a myocardial VT. Similarly, as a corollary to this, you can actually look at distance traveled on the y-axis in the initial 40 milliseconds of QRS and the distance traveled on the y-axis in the last 40 milliseconds of the QRS. And if the initial depolarization is slower than the terminal depolarization, it is again a very specific criteria for butterfly tachycardia. This is again the morphology. As I said, whenever you are dealing with broad QRS tachycardia, look at the QRS morphology in the precordial leads. If they are very specific for right bundle branch block, like on B1, you have a triphasic complex, RSR prime pattern, with R prime more than the initial R. Or on B6, you have a triphasic QRS, the R more than S, a deep S wave. All these things indicate a typical bundle branch block, and whenever you have a typical bundle branch block during a wide QRS tachycardia, it indicates SVT aberrancy. A typical left bundle branch block by definition has RS or a typical QS pattern in lead V1, with the time to the peak of S wave being less than 70 milliseconds. The time to the nadir of S wave should be less than 70 milliseconds. And in V6, you should have a wide monophasic R with absent Q wave. This is the typical left bundle branch block pattern. If you have a wide QRS tachycardia, this typical bundle branch block pattern, it always indicates an SVT aberrancy. On the contrary, in a person with a right bundle branch block morphology tachycardia, if you have a monophasic R in V1, that is only R wave, or if you have a QR pattern, a small q followed by RR pattern, or if you have a triphasic pattern with the rabbit ear pattern, which we say that the first deflection, that is R is more prominent than R prime. Mind you, in right bundle branch block, typical right bundle branch block, the R prime is more than the R. But in BT, you have always R more prominent than the R prime. You can see this rabbit ear versus the typical right bundle branch block on the upper part. So when you have rabbit ear configuration, or on B6, you have an R which is less than S. In a right bundle branch block, it always indicates BT. So this is the Ashman phenomenon, which happens because of a long short sequence impinging on the refractory period of right bundle branch and creating an RBB during supraorbital tachycardia, resulting in a broad QRS. On the other hand, with left bundle branch block, in a normal sinus rhythm or an SVT aberrancy, you'll never have Q waves in V6 in LBB tachycardia, and you will have a very narrow R wave and a sleek downstroke of QRS in V1 during a typical left bundle branch block or an SVT aberrancy. On the other hand, in a VT with an LBB pattern, you will have a broad R wave in V1 with a duration duration of 0.03 seconds. You have a slur or notch in the downslope of S wave. You have a time to nadir of S wave, which is more than 70 milliseconds, which indicates VT. In V6, you can have evidence of a scar in the form of Q wave in an LBB tachycardia, which indicates that it is a VT. So a person has RBB morphology tachycardia if the QRS width is more than 140 milliseconds, if there is a left axis deviation, if on V1 you have a tiny Q followed by a prominent R, or you have a monophasic R, or an rabbit ear configuration, the first R is more prominent than the R prime, or you have a QS pattern in V6, or an R which is less than S in V6, it indicates that it is weak. On the other hand, if you have an LBB morphology tachycardia and the QRS duration is more than 160 milliseconds, or if there is a right axis deviation, if there is an initial R in V1 which is more than 30 milliseconds, if there is a notch or slur in the downstroke of S wave, or if the time from the onset to the slur to the peak of S wave is more than 70 milliseconds, if there is a Q in V6, all of these things during an LBB tachycardia indicates that it is weak. Normally, in a SVT aberrance, you always have some ECG, some precordial lead which shows an RS pattern. But in VT, you'll never see RS pattern. So absence of RS pattern always indicates that it is VT. Even if there is an RS pattern in VT, from the peak of R to the peak of S, the duration is going to be more than 100 milliseconds. Some patterns in V1, which are very specific for them to be VT, is an RS pattern in V1 or this W pattern in V1. These are very specific for ventricular tachycardia. Now, based on all these the theory that I said, there are many algorithms which are proposed. The two common algorithms which you can follow is the Brugada's algorithm and Verreke's algorithm, which has been modified twice. So the most commonest algorithm that you would see is the Brugada's algorithm, which looks at, as I said, the absence of RS complex in any of the precordial leads. So absence of RS complex clearly indicate that you are dealing with ventricular tachycardia. If you have an RS complex in any of the precordial lead, from the onset, from the longest R to the R to S interval of more than 100 milliseconds, it indicates that you are dealing with ventricular tachycardia. AV dissociation or the classical criteria for VT present in in any of the precordial leads again indicate that you are dealing with ventricular tachycardia. So Brugada's algorithm has a specificity of close to 98% and a sensitivity which varies somewhere between 60 to 90%. This is the Verreke's algorithm, on the other hand, which has sometimes an accuracy close to 98 to 100%. Here they look for AV dissociation first. If you have AV dissociation and initial Q or initial tiny R in AVR, which is more than 40 milliseconds, all these things are very specific for VT. If there is a notch on the downstroke of a predominantly negative AVR or a QRS morphology, unlike bundle branch block, it indicates VT. You look at the ratio of the initial deflections, the intrinsic oil deflection, the terminal deflection. If the intrinsic oil deflection is slower, it indicates VT. So you can look at either of these algorithms, but all said and done, the gold standard for always making a final diagnosis, an EP study, where we put catheters inside the heart, electrograms or signals from inside the heart, which we call the electrograms. And during a wide QRS tachycardia, based on electrograms, if you see ventricular dissociation, that is more V's than A and B totally dissociated, this is a sure shot sign that we're dealing with ventricular tachycardia. So essentially to summarize, ladies and gentlemen, out of ECG criteria, the most reliable criteria and easy to apply criteria are looking for AV dissociation, fusion beats, capture beats, the QRS duration of more than 140 milliseconds with RBBB morphology and more than 160 milliseconds with left bundle branch block, an axis which is northwest axis or an axis which changes more than 40 degrees from the native sinus rhythm, a negative concordance on the precordial leads, presence of Q waves during broad QRS tachycardia, or a QRS duration which is narrower during tachycardia than sinus rhythm or specific for VT. So in the casualty, when these patients come to you, look at four things: whether the patient is conscious or not, whether the patient has angina, how hemodynamically stable the patient is, and whether the patient is in pulmonary edema. So suppose the patient has come with a syncope, patient has ongoing angina. If patient is hemodynamically unstable or the patient has pulmonary edema, never try to decipher the mechanism of wide QRS tachycardia. Just treat him with defibrillation as fast as possible. And if they are stable, you try to look at the algorithms that you have. As I said, you look at whether it is regular or irregular. If you have irregular and you have really a polymorphic QRS, it is definitely going to be polymorphic VT. If you have irregularly irregular wide QRS tachycardia and the QRS morphology is very similar to a typical bundle branch block, it's an AF with an aberrancy. If it has a slurred onset and a varying morphology of QRS, it is a pre-excited AFib. On the other hand, if you have a regular wide QRS tachycardia, the QRS morphology is typical of a bundle branch block or very similar to that you see in sinus rhythm. You are dealing always with an SV with aberrancy, although rarely a bundle branch VT can present in a similar way. Subsequently, look at the evidence of AV dissociation, fusion beats, capture beats. If the ventricular rates are more than atrial rates, it's always indicative of ventricular tachycardia. If none of these things are there, again look for a prominent R in AVR, fusion beats, capture beat, northwest axis, evidence of structural heart disease. All of these things are very specific for VT. So to conclude, whenever you're dealing with a wide QRS tachycardia, always try to record a 12-lead ECG if the patient is hemodynamically unstable. In a hemodynamically, if the hemodynamically unstable patient, always defibrillate first. In a hemodynamically stable patient, always try to record a 12-lead ECG. If you're not really clear, based on all the algorithms that we discussed now, it is always wiser to treat every wide QRS tachycardia as ventricular tachycardia. You should always remember that majority of the clinical wide QRS tachycardias that you see in clinical practice are VTs always. Any wide QRS tachycardia in the presence of a structurally abnormal heart like history of prior myocardial infarction or LV dysfunction is almost always very specific for VT. Hemodynamic stability does not indicate the diagnosis. So VT can be hemodynamically stable, supraventricular tachycardia can be sometimes hemodynamically unstable. Baseline ECG always gives you a lot of clue, like presence of pre-existing bundle branch block, presence of pre-excitation, presence of structural heart disease, all in helping us in the diagnosis. Finally, looking at ECG again, if the QRS morphology is typical of a bundle branch block or the baseline ECG shows pre-excitation or evidence of pre-existing bundle branch block, you're always dealing with a supraventricular tachycardia. If the QRS morphology is not similar to a typical bundle branch block, you have AV dissociation, you have fusion beats, capture beats, a prominent R in AVR, if you have northwest axis, a narrower QRS during tachycardia than sinus rhythm, combination of right bundle branch block with left axis or left bundle branch block with right axis, a very slow initial depolarization of the ventricle, all these things are very, very specific for me. So to conclude, you all know that all arrhythmias will eventually straighten out themselves in the end. And I hope this talk would help you in making a difference in this. I hope this talk gives you an idea on how to avoid these QRS straightening out in your clinical practice. So that's on from my side. I'll be happy to take on the questions. I hope this talk was useful for you all, and this is 1 hour down, and let me just see what are the questions on. So I see some questions, okay. So, okay, one question raised up by Mr. Vishnudas is when to use Lewis lead, how it will be helpful. As I showed in my slide earlier, Lewis lead will bring out evidence of AV dissociation because it will clearly bring out evidence of atrial activity. And once you have Lewis lead, you can clearly see evidence of AV dissociation better. I think this slide very clearly shows the use of Lewis lead. Here, Lewis lead brings out P waves very clearly out, and this shows evidence of AV dissociation, which was not seen in the baseline ECG. Baseline ECG, you couldn't see P waves. With Lewis lead, you could clearly see P waves, and that brings out AV dissociation. The next question is VA dissociation, AV dissociation, both favor VT. So see, AV dissociation or VA dissociation, both are synonymous. It indicates atrium and ventricular depolarizations are not associated at all, or go in different planes. They are divorced. VA dissociation, so essentially they are mnemonically same. People say VA dissociation because in VT the number of V's are more than A. So that is why they technically call it as a term of VA dissociation. While with complete heart blocks and all, you have atrial depolarization more than ventricular depolarization. That's when you call AV dissociation. So essentially, mnemonically both are same. It is dissociated activity, depolarization of both atrium and ventricle. VT theoretically has VA dissociation because ventricular activity is more than atrial activity, and the complete heart blocks have AV dissociation with atrial activity more than ventricular activity. So the next question from Mr. Chintan is, can you explain again capture beat and fusion beat, how to differentiate? So he wants to know capture beat and fusion beat. So as I said, so this is a slide which differentiates capture beat and fusion beat. You need to understand, even when the patient has VT, native sinus depolarization continues to happen. So the ventricle is getting bombarded by two kinds of impulse, from the VT focus and from the native sinus node through the His-Purkinje system. Majority of the time, VT rates are much faster than sinus rate. That is why the QRS is always typical of the VT morphology QRS. But sometimes the sinus depolarization can come down the His-Purkinje system and can capture some part of the ventricle, while the remaining part will be activated by the VT focus. In that case, the QRS morphology will not be very similar to the VT of the VT morphology, but would be somewhere between a mixture of the VT QRS morphology and the sinus QRS morphology, which we call as the fusion beat. On the other hand, sometimes the entire ventricle, as the name suggests, can be captured by the sinus depolarization via the His-Purkinje system, and then you can have a P wave followed by a QRS, which is just similar to the sinus QRS. So, as I said in this, you always for fusion or capture beat, you will have a P wave proceeding. If the QRS beat is very narrow, very similar to the sinus QRS, it is capture beat. QRS is narrower, a mixture between the sinus rhythm QRS and the VT morphology QRS, it's a fusion beat. So I think that explains your question well. So a question from Dr. Jayakumar is, why is adenosine unsafe in VT? It has been shown, see, adenosine is not theoretically always unsafe, but it has been shown that in some cases, it degenerates VT to VF, and that is why it is theoretically said that you should avoid using adenosine during VT, although it is in practice very uncommon. The other question from Dr. Satish Kumar is, what are the easy steps for a primary physician to read? What are the easy steps for a primary physician to read an ECG? I think you should go to the basic ECG talk for that. The topic for today was not on that. I think that's about the questions from today. I don't see anything, any more questions. I think these are the questions that I saw. And so that's from my side. So I think I'm done with my talk. I think I don't find anything more relevant. If there is something more, because I can't see anything more on these things. Okay. Okay, there's one other question. I would like to know from Madhu Krishna, I would like to know how to differentiate from Wide QRS tachycardia of VT from pacemaker mediated Wide QRS tachycardia. Some subtle clues are evidence of pacing spikes. The morphology, see, pacemaker mediated tachycardia is nothing but it would just be similar to a VT which originates from the RB apex, or a VT which originates from the site of the pacemaker lead. So you will have a morphology of Wide QRS tachycardia which is just similar to the paced QRS morphology. So that is the sure shot sign of differentiating pacemaker mediated tachycardia from VT tachycardia, from ventricular tachycardia. Just look for pacing spikes, and the sinus rhythm pace morphology would be exactly be replicated during the Wide QRS tachycardia. Can't see anything more. One other question from Vishnudas is, during sinus rhythm, narrow QRS during VT, localization of focus, explain how can. So the one question from Vishnudas is, during sinus, in bundle branch block, right bundle or left bundle, during sinus rhythm, narrower QRS during VT, localization of focus, explain how can it be narrow QRS, we assume during tachycardia bundle branch block conduction improves. So the question that Dr. Vishnudas has put is, the person has a bundle branch block. So if the person has a left bundle branch block, and if the VT originates from left ventricle, the ventricular depolarization of left ventricle is going to be faster via a ventricular tachycardia focus than via the diseased His-Purkinje system. And that is why, in the presence of a pre-existing bundle branch block, if during a wide QRS tachycardia. It is always not that every VT in a person with left bundle branch block arising from left ventricle is going to be narrower. Rarely VT in a person with left bundle branch block, if it becomes narrower during the tachycardia, it indicates that the VT is originating from ipsilateral ventricle. Yeah, I think I've answered most of the questions. These are the questions that I got through. If there are something more, the host or Dr. Lawrence can let me know. Thank you. I will be signing off. Thanks for this opportunity, and stay home, stay safe, and God bless you. Thank you. So I'd mute myself, and I would hand over the proceedings to my close friend and colleague, Dr. Lawrence, to take over. Thank you.
Hi. Hello. Hi. Thank you, Dr. Arun, for an excellent talk. We really enjoyed it. Really a complicated talk made very easy by Dr. Arun. I was very happy to see 1,300 plus audience for a ECG talk. It shows a level of interest in the talk. I had few questions I have seen in the questions that some people have asked for a basic explanation of ECG. I think you may be aware that this is the third in our module. We have already completed our talks on basic ECGs. These are all available in our COVAI Heart Rhythm Summit YouTube channel. If you want, you can go through that. We have excellent talks on basics of ECG. With that, I'll start my talk. Coming from a complicated wide QRS tachycardia, my presentation for today will be on utility of an ECG in non-cardiac conditions, a case-based approach. As you see, during the previous interactions, we had a lot of questions on this. So I thought of taking this part of ECG, which may be very interesting and very important for a clinician point of view. Today's topic, I'm going to cover few of this. You know very well there are a lot of changes drugs can cause on ECG. There are some non-cardiac conditions which have a significant impact on the ECG. And we have few ECG mimics. You know very well that patients with pneumothorax can have an ST elevation. Patients with acute cholecystitis presents with ST changes in ECGs. And patients with acute pancreatitis, there are case reports which are present with a significant ST changes that people mistook for myocardial infarction. So these are all typical ECG mimics. You see a patient with subarachnoid hemorrhage. We have seen a lot of patients. One of the cardinal electrocardiogram sign is a T-wave inversions, huge T-wave inversions in anterior leads. See, I'm not going to see all of this because we know very well that most of them are clinical diagnosis. Whenever you are reading a ECG, most important thing is never look at ECG in isolation. Whenever I get a ECG for reading, also I always say, give me a background history and all that, because ECG has to be read along with a history. Just looking at a ECG and making diagnosis is not right. So another most important part of electrocardiogram, which is very useful, is electrolyte imbalance. We can get a lot of information on this by looking at a ECG. We have a lot of drugs and toxins which have direct effect on heart. All these toxins can have a ECG changes. There are some cardiac toxins like oleander which can cause bradycardias and ventricular arrhythmias, and there are toxins which can cause bradycardia if they are acting on vagal system, and most of the toxins, irrespective of their action, can have a sinus tachycardia because just an anxiety could be the reason. And specific toxins, according to the way they act, will have a manifestation on ECG. There are a lot of things to be talked on this, so I'll select few cases and go through that cases. If any specific questions you make, I'll try to answer it in the Q&A session. So I'll keep this format as a case-based approach because I thought this is a clinical question, so we'll go clinically. This is a 72-year-old female, had a recent TKR. On a post-op day 4, we have been called for a sudden onset of breathlessness. Chest X-ray was completely normal, already seen by a physician. Chest X-ray was normal. Patient is hypoxic, saturating close to 70 to 80% on room air with a hypotension. BP is around 90 systolic. By now, we'd have made a picture on our mind what we are looking at. So the ECG was taken. This was a ECG. just looking at the ECG, everybody would have jumped to the diagnosis. We know very well what is this ECG is all about. So you just look at this ECG, it's a typical S1, Q3, T3 with not so good progression on the V1 to V4. If you see, there's a significant prominent right ventricular pattern. Your left ventricle has not seen clearly on this ECG. So this is typical of a acute massive pulmonary thromboembolism. You see here, I've made it a little more obvious. You can clearly see a S1, Q3, T3 pattern. There is a deep S in lead 1. There is a T wave inversion in lead 3, along with a deep or somewhat Q wave in a lead 3. This is a constellation of all three signs. We call them as S1, Q3, T3. Other things you always look at in patients who present these kind of findings is looking at RV strain. This RV strain can present in multiple ways in your ECG. You can see a right bundle branch block pattern, either complete or incomplete. You can have T wave inversions in the anterior leads like V1 to V3, which we usually look at as a right ventricular leads. This T wave inversion can be present from V1 to V6. And you can see the lateral R waves are not that prominent. We usually see a prominent R waves in V4 to V6, but they are not seen. These are the signs that your right ventricle is strained out. So one of the common reason for acute onset of RV strain pattern is pulmonary thromboembolism. So whenever you look at a ECG with pulmonary thromboembolism, what you are looking at is a RV strain. These are the clinical, when you see clinically a pulmonary thromboembolism, these are the ECG manifestations of a RV strain. You always remember ECG is helpful in diagnosing a RV strain and pulmonary thromboembolism, but a normal ECG never rules out pulmonary thromboembolism. This is an additive or adjunctive finding in patients with pulmonary embolism. This is very important. When you look at pulmonary thromboembolism diagnosis by ECG, most often you see a non-specific ST changes and a tachycardia. The sinus tachycardia is a very prominent and most common sign. You can see close to 50% of the patients with pulmonary thromboembolism have sinus tachycardia. And you can have RV strain patterns, which is very suggestive of a severe pulmonary embolism. You can have inverted T waves from V1 to V4. You can have a QR in V1, incomplete or complete right bundle branch block pattern, and the classical S1, Q3, T3. You have to understand that this is seen in 20%. That is, if the patient has a massive pulmonary embolism and has a severe RV strain, close to 20 to 30% of the patients can have a SQ3, Q3, T3 pattern. That means presence of this gives you a clue. Absence of this does not exclude a pulmonary thromboembolism. So pulmonary thromboembolism is a clinical diagnosis aided by electrocardiogram. The next one is a 20-year-old primigravida. Gravida. This has a lot of relevance now with the present situation of COVID. Patient had a fever, jaundice, and altered sensorium for 5 days. GCS was 12/15. Blood smear for positive for Plasmodium falciparum. A diagnosis of a cerebral malaria was made. The huge parasitic index of 10%. The patient was started on a quinine infusion. On day 2, patient developed a sudden hypotension. BP is hardly 80 with a heart rate more than 200. It's a clear-cut Torsades. So it's a polymorphic VT. You can see a ST. You can see a ECG here. There is a polymorphic VT. We typically call it Torsades or rolling around along the axis. This is typical of a ECG due to a QT prolongation. You compare with this monomorphic VT. I think Arun has discussed in detail about wide QRS tachycardias. It's a monomorphic VT where you can see every QRS complex resembles each other. If you look at any lead, the previous, preceding, following QRS complexes resemble each other. They all along the same axis. Compare with this ECG, there's a complete change in axis nearly in every beat. This looks like this is a polymorphic VT. So this patient has developed a polymorphic VT secondary to the drug. So these polymorphic VTs immediately requires a defibrillation as a ventricular fibrillation because this is hemodynamically unstable. The drug of choice remains IV xalocaine because we have most of the antiarrhythmics which are QT prolonging. The most common reason you will develop these kind of polymorphic VTs are due to metabolic disturbance, and this is, you know very well, people who are seeing cardiac patients regularly will know that one of the earliest manifestations of cardiac ischemia, coronary artery disease, which is presenting as a myocardial ischemia, could be a polymorphic VT. So these are the most common reasons why you will see a polymorphic VT. This can be associated with a prolonged QT. Whenever a polymorphic VT is associated with a prolonged QT interval, we call them as a Torsades-T pointers. So a polymorphic VT is most commonly secondary to a metabolic disturbance, drugs, or cardiac ischemia, which have an act on cardiac repolarization. So Torsades-T pointers, if you see, when you have a polymorphic VT associated with a longer QTs, there is an increased risk whenever your QT extends beyond 500 milliseconds. And if your QT goes beyond 600 milliseconds, you have a very high risk of developing a Torsades-T pointers. This is particularly true in female patients. They are very susceptible to Torsades. And when you have patients with QT prolongation, give a drug which can further increase the QT, like what presently happening whenever you are giving a chloroquine or azithromycin on a patient for a treatment of a COVID, you have to be very careful about your QT prolongation. QT has to be monitored regularly. We have a history of patients. We recently lost a young boy here who had a baseline QT prolongation, was given chloroquine and had a Torsades. So you have to be very careful whenever you use a QT prolonging drugs to make sure that you have seen a baseline QT. This is particularly important in younger patients because as you know, long QT syndrome, it's a congenital QT prolonging syndrome, which is more common in children. So whenever you are looking at children and treating them with any QT prolonging drug, your baseline ECG is a must. So most often your Torsades is frequently initiated after a pause. It's mostly iatrogenic, and this usually patient will have a background hypokalemia, hypermagnesemia. The patients can have a drugs which can prolong a QT, and usually it's a combination of these. You can have congenital long QTs. We know very well that there are a syndrome of long QT syndromes which congenitally due to channelopathies, which can cause prolonged QT. You will have a lot of patients who have acquired, or we have seen patients who have a completely asymptomatic, never had a longer QT, suddenly started on some drug and it manifests itself. They may have an inapparent long QT syndrome, but slowly when you give us some drug which can prolong, or you cause some situation which prolongs QT, can end up in a QT prolongation and polymorphic VT Torsades-T point. It's a dangerous one. If we don't treat properly, there's a possibility that you may lose the patient. There's a huge list of drugs which can cause QT prolongation. You always have in mind whenever you give a QT prolonging drug. You look at your drug chart, make sure that you are not mixing two QT prolonging drugs at the same time. And whenever you are going to use a QT prolonging drug, you know this drug is going to prolong the QT, make sure your electrolytes are in range. I always tell that whenever you have a drug which is going to prolong a QT, make sure your potassiums are in high normal side. You have a normal magnesium. The calcium, we don't check so frequently, but in susceptible patient, you may have to look at calcium and magnesium also. So the most important thing is looking at a potassium levels. Potassium has to be kept at a longer level. And before starting any QT prolonging drug, make sure you have a baseline ECG and monitor the QT regularly in these patients to avoid this disastrous consequence of a QT prolongation. How you treat these Torsades? Most important thing is remove the offending agent immediately. Whatever the drug which can cause slightest QT prolongation also has to be pulled out. We have a list of drugs which can cause a tremendous QT prolongation, and we have drugs which are usually okay. We don't see lot of times, lot of antibiotics can cause a little QT prolongation, but when you have already a QT prolongation, all offending drugs has to be taken off. Replete potassium. I love my potassium levels to be more than 4.5 in patients who have a longer QTs. Treat with magnesium even if normal. You see, it's very difficult to find out intracellular magnesium levels. You did a extracellular magnesium levels, which may be normal, close to normal, still patient can be depleted with the intracellular magnesium stores, which is more important for patient's action potential. So that is going to cause further trouble. So if you feel the magnesium levels are normal also, there is no harm in repleting magnesium as long as your renal function is good. If the patient has a good renal function, your infusion of magnesium is not going to cause much of trouble. You have always to increase the heart rate. Whenever your patient has a Torsades or longer QT, The worst thing here can have in association is a bradycardia. Always bradycardia increases QT furthermore, and patient will become more susceptible to arrhythmias. So you try to increase your heart rate. So this is very important. So this is one of the very few situations we know about isopranoline as a drug. We know very well from our experience from treating ischemic heart disease patient. A lot of you, I think, at least our earlier generation cardiologists and physicians will be well aware of this drug, particularly given in myocardial infarction patient. They are very pro-arrhythmic. I always say this is one of the very few situations where isopranoline is used as an anti-arrhythmic agent. You give an isopranoline infusion, keep a heart rate more than 100, 110, so that QT interval remains stable, so the patient can be treated. Sometimes you may not be able to achieve that. We may have to put a temporary pacemaker and pace the heart more than 100 beats per minute. So keeping a heart rate higher is a treatment for a prolonged QT interval and torsades. If you have a congenital long QT syndrome, you have treatment options available. We know very well there is a list of drugs, and beta blockers are extremely effective in type 1 and 2. And some of the patients who are not even symptomatic, even on beta blockers, may require a further treatment like ICD. But that's not part of my talk today. So we'll keep with repleting the electrolytes. And along with that, if you want, you can try to increase heart rate. So next one is a 60-year-old man had a CA stomach, underwent a total gastrectomy. 3 days later, he becomes breathless and febrile, had a multiple ventricular ectopics associated with hemodynamic instability. So cardiologist was called. He has been intubated. Most of the common causes have been ruled out. Looking at a ventricular ectopics, cardiologist wanted to start a amiodarone infusion. He was started on amiodarone infusion. Next day, that's the ECG. So the patient has a complete heart block. You can see that AV dissociation. And what you can observe very clearly is background QRS prolongation. This patient already had a baseline biphasical block. He has been started on a amiodarone infusion. So patient developed a complete heart block. Patient has to be temporary pacemaker was done. The lower panel, you can see a temporary pacemaker has been done. And slowly his heart rate improved and TPA was taken out. So one thing you should always remember is most of the drugs, including your antiarrhythmics, can be pro-arrhythmic in particular patient. So all patients with amiodarone infusion, once stabilized, slowly overlap to oral and taper the infusion. Keep a close watch on conduction system. Although amiodarone is not as bad as your beta blockers or calcium channel blockers and conduction system, it can reduce the sinus rate. It can have an act on AV nodal tissue. So patients who have already a susceptible AV node or susceptible conduction system, patient can develop a high-grade AV block or significant bradycardia. So you should always be worried about this, particularly in patients who have multiple comorbidities. Patient had a liver dysfunction, particularly an ICU patient where half-life of amiodarone can be significantly prolonged. You may take a longer time for the amiodarone to return to normal levels so that your conduction system recovers. So be careful whenever you give any drug which is going to affect a conduction system. There's another patient, a 28-year-old female, had a post-MVR, admitted with AF with fast ventricular response. Had a significant congestive heart failure. She was kept on high-dose diuretics. She required a pretty stiff dose. She was getting somewhere close to 180 to 200 mg of furosemide, and she was well under control with amiodarone. So we were thinking she's doing really great. We shifted her out of ICU. When we are shifting into lift, she had a cardiac arrest, revived. So ECG post-resuscitation, glaring. See, this patient had a significant prolongation of QT. What you have done, you have given a lot of diuretics. Along with that, patient was on amiodarone infusion. So this patient had a mile-long QT. You can see that QT interval is nearly obscuring the next P wave. You will hardly see a P wave, particularly in the precordial leads. This is a pretty long QT, and patient has developed a torsades. This is the recorded strip from the defibrillator. So the patient, if you look at the patient's reports, patient had a potassium of 3.6. I would say that's not very low, but you have a significant magnesium depletion also. Patient had a combined depletion of a magnesium and potassium, which caused a significant prolongation of QT. Along with that, you have a hypothyroidism. On top of all three, patient was on amiodarone infusion. So you have to be very careful when you have multiple factors which are going to cause a QT prolongation. Particularly cardiac patients, you know that we are particularly congestive cardiac patients, we are going to give a lot of diuretics. You are going to deplete good amount of magnesium stores, and patients supposed to have a potassium low also. In this patient, if you see, this patient was on a reasonable repletion of potassium. She was given potassium repletion in the form of oral potassium, but as long as you don't correct your magnesium, your potassium is never going to increase. So this patient was on borderline potassium all the time. Potassium was in the range of 3 to 3.5 all the time. So when you have these kind of patients who have a resistant hypokalemia, you would always look at magnesium levels and replete magnesium. The moment you will replete magnesium, the potassium levels will also improve. And when you have these kind of a situation, your TSH is 15. Normally, you may have wanted to wait for some time, do a lot of testing before starting a thyroid replacement. These kind of patients, you may be a little more aggressive in giving thyroxine, because these patients have so many factors which can prolong the QT. So QT interval measurement is very important. Every one of us should know how to measure a QT interval. This is very, very important. I think we had one extensive talk last week by Dr. Natarajan sir, who explained extremely well on how to measure and how to look at QT intervals. QT intervals have to be measured from a start of QRS complex to the end of the T wave. What you are doing by this, you are measuring complete total ventricular activity. You are including depolarization, which is represented by a QRS, and repolarization, which is part of your SC segment and T wave. So you are measuring the total ventricular activity and total refractory time of your cardiac action potential. QT has to be corrected for rate, because QT is a dynamic thing. During a bradycardia, QT prolongs, tachycardia, QT shortens. So you have to measure and correct it with your heart rate. There are a lot of formulae for available for this correction. The most commonly used is Besset's. You measure a QT interval, RR interval. QT by square root of RR interval gives you a QT number. Most of your smartphones have algorithms. You have MD-Cal kind of an app which can immediately just measure your QT, measure your RR, put them in the formulae. They will give you a QTC. If you are not having access to all this, you just measure your QT interval given by your automated ECG. Lot of times, the most common mistake in QTC measurement happens in the calculation of QT, because a lot of time your automated machines will not be able to clearly see the end of T wave. So they may overestimate or underestimate the QT interval. So if your automated machine gives a proper QT, your QTC will be correct, because RR interval is easily measured by your automated machine. So you just measure your QT interval in your ECG and see that your automated ECG has given a proper QT. If your QT interval of the automated ECG is correct, your QTC given by a automated machine is also correct. Other way to look at it is whenever you see a ECG, just look at the RR interval. If your T wave ST segment T wave crosses half of your RR interval, then you are looking at a prolonged QT. This is another easy way to see. It should be less than half of RR interval. So if you see your QT interval is crossing more than half of QT interval, then you are having a prolonged QT. Keeping a good eye on QT interval is very important whenever you are looking at a electrolyte imbalance, because most common arrhythmia you're going to see with prolonged QT is a ventricular arrhythmias like TACHYCARDIA, which are life-threatening. If you are not available, you are not aware of it, and the ECG is not monitored, there is high probability that you may lose the patient. So third one is a 26-year-old man run over by a truck, managed in a local hospital, brought to casualty 24 hours later. Had a multiple head injury, crush injuries. His GCS is 10/15, pressures are 90, and heart rate is 46. He has bradycardia. He was admitted in ICU, was stabilized. This is the ECG. It's a very classical ECG, right? Anybody who just look at the ECG can make a diagnosis. What you can see is a tall, tender T waves, typical. And another thing which is very typical you have to understand is a absence of a P wave. You are not seeing any P waves here. Patient looks like it's in a junctional rhythm. You see a QRS little wider. Patient is in a bradycardia. So you have classical findings of tall, tender T waves, absent P waves, broader QRS, and bradycardia. All this in this patient is going to say that just look at potassium level. That is very important. It's a classical signs of a hyperkalemia. So when you did a bloods, your creatinine is 4.5, potassium is 7.1. So ECG has given a clear clue what to do next. So hyperkalemia is a one electrolyte imbalance which can give you a lot of ECG clues. As your potassium level rises, there is a sequential changes in the ECG. When your potassium levels are in around the range of 6.5 kindish, you will see a tall tented T waves. Your T waves are becoming upright. Once you reach a level of 7 plus kind of a thing, your T waves still rises further. Slowly you will start losing your P wave. Losing a P wave is a very dramatic sign of a hyperkalemia. So the earliest sign will be a peaking of your T waves, followed by broadening of QRS, and slowly you lose the P waves. When you lose a P wave, and ultimately when your potassium levels goes more than 10 kind of a thing, patient will develop a sine wave and can have an asystole. So potassium levels are, looking at a potassium levels is very important when you see a subtle changes in your ECG. Whenever you see a any arrhythmia in ICU, see in a non-cardiac patient, whenever you see arrhythmia, looking at the electrolytes is very, very important, particularly potassium. You have to focus on treating this underlying dysarrhythmia promptly. This is more important. Treat the underlying cause rather than jumping and treating your arrhythmias. Just treat the underlying cause, your arrhythmias will be settled. Why this dysarrhythmia has such a dangerous consequences on your heart? Because all your action potential is completely controlled by your ion channels. These ion channels are nothing but your ion, your positive ions going and negative ions coming out. So when you look at this diagram, you know how your electrolytes are important in keeping your heart rate and all your PR, QT and QRS interval intact. So you see here. And another thing you have to look at is see the relevance of your potassium channels in cardiac action potentials. Sodium channels are active hardly in your phase 0 and 1, and calcium channels in phase 2, while all other phases potassium is involved. So potassium is an important component of your action potential. Entry and exit of potassium is very important. When you have a hypo or hyperkalemia, your action potential is dramatically affected. And you know very well that the most important phase of your action potential, the most important phase or place where most of the arrhythmias happen is a refractory or repolarization period of your action potential. You see, when your action potential starts recovering from positive to negative, when you start from the middle of this phase to the complete repolarization, this is the phase your heart is very susceptible to arrhythmias. And look at this phase is completely controlled by your potassium. So that's the reason your potassium levels are very important to look at. So if you look at electrolyte imbalance, which can have a significant cardiac manifestations, hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, hypomagnesemia, they can all have a significant effect on your cardiac action potential, thereby manifesting in an ECG. Others like hyponatremia and hypernatremia, they don't have much of changes. They can have minimal effect. Acidosis and alkalosis, by acting on again potassium and calcium, can have an effect on your action potential. Hyperkalemia, if you look at, whenever serum levels are above range, you can have ECG manifestations. Most common cause is usually renal failure, and a lot of our cardiac patients you know very well are on ACE, ARBs and aldosterone antagonists, which can all cause hyperkalemia in patients who have a relatively fragile renal function. Sinus node can stop, or you don't see any longer P waves when your potassium levels go up more than 7.5. A VF or asystole can occur at the level of 10 to 12. The T waves in hyperkalemia, which is a very important finding. Your T waves in hyperkalemia is typically tall, narrow-based. They don't have to be very tall. So your tall is a comparative scale. So tall T wave is usually more than 2 big boxes in a precordial lead, or more than 1 box in a limb leads. Or more importantly, in your mid precordial leads, your T wave is taller than your QRS complex. Then although your T wave by qualitative terms may not be taller, but still is taken as a taller T wave. So you have a taller T wave by qualitative amount more than 2 big boxes, or you have a T wave which is taller than the QRS complex, you call it as a tall T wave. And you know very well that typical hyperkalemia T wave is short based with a peaked appearance. So that's a typical of a hyperkalemia. So what I already told you, what happens to start with, your T waves become taller with a narrow base, and slowly your QRS starts widening. And you will start seeing that your ST segment slowly disappears and taken over by your T wave complex. And T wave grows further and further, and P waves gets absent. And ultimately, by just let's look at the T portion of the figure, and you will see a sinus wave in severe cases. You don't want to allow your patient to reach that stage. So you pick up the hyperkalemia earlier and treat it. The next one is a 52-year-old male, post-anterior MI, has a severe LV systolic dysfunction, has a congestive class 4, admitted in CCU with a high dose diuretics, complaints of fatigue and vomiting, which is very common. Most of our heart failure patients are going to complain of this. This is a day 1 ECG. Somebody has seen the ECG and look okay, reasonably okay, not to be done anything. And second day, you can see a significant prolongation of QT. The first ECG itself, you can see a prolongation of prolongation of QT interval with appearance of, if you see very closely in V2 and all, you can start to see a T wave. T wave getting prolonger and U wave becoming slowly appearing in the ECG. By day 2, with that itself, patient has continued to have a diuretics. Potassium was not replaced. You see a huge, big, tall, prolonged QT along with a very prominent U wave. So potassium goes further down. You are seeing a very prolonged QT interval. You hardly see a T separately. Your T and U are fused together. You have a prolonged TU wave. So patient has developed a significant QT interval prolongation. So if you look at hypokalemia, these are the common ECG finding you will see a hyperkalemia. The ST segment get depressed. T wave starts to flatten or join U waves. You will start seeing a flattening of T wave with prolongation with a prominent U wave. The U waves slowly will get larger and larger, and they will become at some stage larger than the T wave, and QT interval will slowly prolong. You have to call it as a QT first, then it will become a QU interval. So the QT QU interval will become prolonged, and PR interval also increases because conduction system getting affected due to very low potassium levels. So this is how it looks like. You start developing a flat T with a prominent U. Slowly your T goes further down, U becomes prominent. Ultimately, you end up in a prominent TU wave and with a predominant prolongation of a QT interval. So as these are typical findings you will see as your potassium levels go down further and further. So you can see here, I have done a schematic way how it looks like. Flattening T wave, absent T wave with a prominent U wave. Slowly you become a TU wave, and this QU interval is prolonged very much. This patient is very susceptible to cardiac arrhythmias. If by chance this patient is on digoxin, then arrhythmias. Digoxin is a one drug you have to be very careful, because this drug is very dangerous when patient has a hypokalemia. Whenever you are giving a digoxin for a heart failure patient, make sure your potassium levels are checked frequently and you kept at a high normal level. If you look at hypo and hypermagnesemia, you cannot call it as some typical ECG manifestations. Although that hypomagnesemia will have a prolongation of QT interval, and serum levels, unlike your potassium levels, hardly correlate. You may not have a significant like level to level ECG manifestations. So you may have a significant hypomagnesemia, patient may not have a ECG finding so typical of it, but while not so high level of hypermagnesemia, patient can have a shorter QT interval. So they don't correlate that much. So if you look at hypermagnesemia, they are more neurological than cardiac. Hypomagnesemia, you will see a lot of ECG changes. Hypermagnesemia, patient presents with neurological findings than the cardiological findings. A 55-year-old man had a post-CA bladder, presented with ED with abdominal pain, had a weakness and fatigue. Look at this ECG, something is striking. See, whenever you look at a ECG, you have to be schematic. You have to look at rate, rhythm. You finish all that and come back to intervals. Look at all the intervals very clearly. You see a PR interval, QT interval. What is striking here is a shorter QT interval. So this patient had a hypercalcemia. All parameters were within normal range. So when the calcium level goes up, you start developing a shortening of QT interval. Hypercalcemia will result in a short QT interval. This is the one way to identify, although it's not very correlative, unlike your other electrolyte imbalance. You can identify hypercalcemia by looking at your QT interval. Hypocalcemia, like your hypomagnesemia and hyperkalemia, can cause prolongation of QT. You have to understand that most of the drug you use, like diuretics, are going to deplete potassium, magnesium, and calcium, all three together. So that's the reason you have to be very careful with electrolytes imbalance in patients who are on diuretics, particularly heart failure patients. So hypocalcemia, if you look at hypocalcememia, the prolongation of QT interval is more at the level of ST segment. If you compare with your long QT syndromes, typical long QT syndromes, except for a long QT type 3, where you will have a long ST, other long QT syndromes usually have a prolongation of a ST segment as a whole. But here you will have a long ST segment followed by a small T wave. This is typical of a hypocalcemia induced long QT. By this, you can identify that this may not be a typical congenital long QT syndrome, at least not type 1 and type 2. So both hypo and hypercalcemia are less arrhythmogenic than with potassium levels. They have other manifestations other than cardiological. As I told you, if you have seen the action potential, you know very well that why hypokalemia is so dangerous, because that's the one ion which is involved from all phases of action potential. And more importantly, your repolarization of cardiac potential is brought about by potassium. So anything you are doing at the repolarization is going to make your heart more proarrhythmic. And potassium is the ion where it's working on completely on that area. That's the reason the potassium disturbances are the most arrhythmogenic of all. In a single patient, as I told you, multiple electrolyte imbalance can coexist, because reason for having a dyselectrolytemia may be the same drug or same reason. So multiple electrolyte imbalance can coexist. You have to be careful about and correct all of them. If you want me to summarize the findings of electrolyte imbalance, hypokalemia, you will have a decreased T wave amplitude. Slowly your T wave will invert. You can have ST segment depression. You start developing a prominent U wave. Slowly, as your potassium levels goes down, you will have a prolonged QT interval or prolonged Q2U interval, and patient will be very much susceptible to polymorphic ventricular tachycardia, particularly TACHs. Hyperkalemia, which is in a milder level, you will have a large amplitude T waves, peaked or tented T waves. When it rises further, you will have a PR interval prolongation. Slowly, your P wave amplitude comes down, and ultimately your P wave disappears, and QRS prolongs, and you will develop as conduction blocks with escape rhythm, junctional escapes, or a wide ventricular escapes. When it is severe, you will see a sine wave pattern in your ECG that is deadly. Ultimately, the patient will end up in a ventricular fibrillation or a rhesus stroke. Hypercalcemia, patient will have a prolongation of QT interval. Patient can develop ventricular arrhythmias. As I told you, as a standalone, hypercalcemia is less arrhythmogenic, but seeing a standalone hypercalcemia is not very common, except for few patients who have undergone a thyroid surgery or like that, who can have a very low calcium levels and can have a very long prolonged QT intervals and can have ventricular arrhythmias. Otherwise, most often hypocalcemia coexists with other electrolyte imbalance to prolong the QT interval to cause ventricular arrhythmias. Hypercalcemias can cause shortening of Q intervals. In some patients, it can cause bradyarrhythmias. Hypo and hypermagnesemia, there are no unique electrocardiographic abnormalities, but often associated with other calcium abnormalities or potassium abnormalities. They will manifest together rather than alone. But as I already told you, hypomagnesemia is a very important thing to be look out when you have a resistant hypokalemia. That's the one reason your potassium level never goes up. Until unless you correct hypomagnesemia, your hypokalemia will not be treated. And most importantly, you know, and you have to remember very well, rather than non-cardiac patients, in cardiac patient, these ion imbalance is very important, because most of your antiarrhythmics are going to prolong the QT interval. You have a lot of drugs, you have a lot of interactions with ion channels. In that background, if you have a background electrolyte disturbances, there's a high probability that you will end up in an arrhythmia. First and most important step in identifying all these arrhythmia is being aware of it. So you should know what you are looking at in your ECG. Most importantly, basics. Look at your ECG in a schematic way, regular way, and always when you are a physician or a cardiologist involved in managing sicker patients, having a mind on QT interval is very important. One of the most common part of ECG which is missed most often is a QT interval. If you are aware of it, I always tell all my juniors, the most important thing they have to do is, after writing all the finding, every patient, they have to mention a QT interval. That's how you realize QT is getting prolonged. Otherwise, in a usual daily rounds, you may miss a early QT interval prolongation and go on giving the offending drug and ultimately end up in a disastrous ventricular arrhythmias. So all of you who join me, we are going to have a next module which is going to be on pediatric arrhythmias. We are having it on May 17th. Dr. B.R.J. Kannan from Vadamalayan Hospital, Madurai, and Dr. John Roshan, cardiologist, electrophysiologist from CMC Vellore, will join us with pediatric arrhythmias. Dr. Kannan will take on basic reading of pediatric ECGs, while Dr. John Roshan will be giving us glimpses and will a detailed explanation of pediatric arrhythmias. So do join us next week also. As I already at the start of my presentation, I told you, like most of our presentations are given in video format in our YouTube channel, which is COVAI Heart Rhythm Summit. You can look at it channel, and the previous all the talks are there in that. You can look at them, and if you are interested, you can go through them. So that channel name is COVAI Heart Rhythm Summit. So you can always look into channel and see that. Let me see the questions. If we have a lot of questions, I'll go through it. Lot of questions. Let me see. There is a question from Hyderabad, Dr. Naresh. Is there any role of routine supplementation of magnesium for prolonging QTC post anti-wall MI? You see, we don't supplement routinely every patient who has a what do you call anti-wall MI or acute coronary syndrome with magnesium. So what usually we do is we look at QT intervals. If the QT intervals are prolonged, then we may consider giving a magnesium. If a magnesium is depleted, then we will give. Usually it's not a in every patient we don't give a magnesium supplementations. So next. What drug we commonly use for VT? Dr. Sandeep Gupta. I think just be online. Let me get my slides if possible. Just be online. I'm giving you a lot of people have asked for the link, so I'm just trying to put that link for your presentation. Looking at all these presentations. Okay. So this will be the channel on which you are going to see that presentations. Wide complete or block patient VT, evidential pacemaker, what drugs we use for role of overdrive suppression VT, if patient has a TPA in post-op bypass, drug of choice with wide QRS tachycardia, secondary to antegrade conduction through accessory pathway. Arun, are you in line? Dr. Arun?
Yeah, I'm there. Yeah.
Dr. Arun, you have a question?
Yeah.
Drug of choice for wide QRS tachycardia, secondary to antegrade conduction through accessory pathway.
Okay.
You want to take it? Yeah.
Yeah. So the question was the treatment for a pre-excited SVT, especially pre-excited AFib or pre-excited flutter. Typically, most of these patients have hemodynamically unstable, and the treatment of choice is always to immediately defibrillate them. While if you want to use a pharmacological agent, the treatment of choice as per guidelines is procainamide, but unfortunately procainamide is not available with us. But you should always remember to avoid using AV nodal blocking agents for any person with pre-excited AFib. Like beta blockers, calcium blockers, or adenosine should be are contraindicated in patients having pre-excited AFib.
Okay, thank you. I think you already discussed, Arun, importance of AVR morphology during wide QRS tachycardia. I think you would have shown the algorithm,
Yes,
right?
yes. I think as per the Veracchese algorithm, you'll realize AVR if there's a prominent R wave in AVR, or if there is a if there's an initial Q which is more than 40 milliseconds, or if there's a slur in the initial downstroke of AVR, all of these things are very specific for VT. And Veracchese algorithm is one thing which gives a lot of emphasis to all these things.
Yeah, there is a question on, I'll take the question, you can also give your inputs. Whether the ibutylate is useful or polymorphic VT, I think ibutylate also prolongs QT, you are not going to use it. When you are looking at polymorphic VTs, we differentiate them to two types. One is patients with a background prolonged QT and patients who have a normal QT interval. When you have prolonged QT and tossets, none of the QT prolonging drugs has to be used for the treatment. So xylocaine or lidocaine remains the drug of choice if you look at an antiarrhythmic agent other than reversing the primary cause. When you have a polymorphic VT with a background normal QT, if you have a documented normal QT with a background polymorphic VT, including amiodarone, your drugs can be used. But I would say that safely, until unless you are very sure about QT interval, better to avoid amiodarone. Arun, your take?
Yeah, basically you should realize that ibutylate is one of the drugs which causes polymorphic VT. So in fact, we would pre-treat patients with magnesium to prevent polymorphic VT when you're treating with ibutylate. So ibutylate is generally, I would say, as a take-home message, contraindicated in polymorphic VT.
Yes, that's better. That's the reason I think one of my slide had treatment for polymorphic VT amiodarone also. I purposely deleted amiodarone because I don't want to give a wrong information that it can be given. You always make sure you measure the QT interval properly. I would rather say that avoid all QT prolonging drugs in your polymorphic VTs. Another question was, does drinking alcohol can precipitate VT in a known old myocardial infarction patient? Arun, you want to take it?
Essentially, you should realize that alcohol is not a proven pro-arrhythmic for the ventricular myocardium, although you know that with holiday heart syndrome, you can have atrial fibrillation precipitated by alcohol. But it is not, unless you have electrolyte disturbances precipitated by alcohol like hypokalemia or hypomagnesemia, alcohol per se does not precipitate VT in structurally abnormal hearts.
Anything else left? I'm just looking at. Hope we are done. Role of overdrive suppression of VT if patient has a TPA. Yeah, definitely. Like, you know very well that whenever you have a VT, particularly your VT rates are on the lower side, you can always overdrive and try to suppress. But whenever you do a overdrive pacing for a VT, you make sure you have a defibrillator available close by, right? Because when you pace ventricular at a faster rates, there's a possibility that you may induce a ventricular fibrillation. You know very well that most of your, particularly if you are using the Medtronic one, it will not give a higher rates at the usual place where you increase your heart rate. You have to open up the top of your TPA panel where it usually gives you a atrial overdrive pacing option. That you may have to select when you are pacing for a VT to overdrive. The most importantly, I would say that rather than for a regular VT, which is at a rate of 150, 180, 200, the most common place where your overdrive pacing is very useful is a polymorphic VTs. Polymorphic VTs, if you keep your heart rates more than 100, 110 most of the time, either by drugs or TPI, the chances of recurrence of polymorphic VT until you get a control over the electrolytes, you may buy a time. Once your heart rate is kept little higher, you do better. So that's the one place where I see it's useful. I think most of the questions we are done with. Any other questions we can always will be happy to get forwarded by the representatives, or you can mail us. We'll be able to answer you if you have missed any questions. Thank you, Dr. Arun, for your excellent company and wonderful lecture. Hope we'll continue this in future also. Very nice meeting you all. Take care. Bye.
Thank you. Thank you so much, sir.
Thank you.
Thank you. Thank you. Thank you so much, sir. It went really nice, sir. Close to 1500 plus, sir, logins.
Oh, great. Nice.
Yeah, really, sir.
ECG always has a lot of interest, and I think hopefully we have given a good presentation. And as I told you, we'll continue this in future also. Anybody who's interested in specific topics can let us know.
Yeah, we'll get it, sir. We'll get it from the vendor very soon.
Sure.
We'll get entire details of the participant. From across country, people are logged in, sir.
I just saw